All right. Welcome, everybody. I'm so glad that you're here. Thanks for joining us. I'd like to ask all of our panelists to introduce themselves, and we'll start with Dennis.
Yeah, my name is Dennis Goluson, and I am going to be celebrating my 59th year of being a T1D or juvenile diabetic. I am volunteered for JDF, Juvenile Diabetes Foundation, the Juvenile Diabetes Research Foundation, and also a volunteer for Breakthrough T1D. And it's been a long journey, but it's been very satisfying.
Great. Thank you, Dennis. Jessica, how about you? Can you tell us a little bit about yourself?
So I had type 1 diabetes for 50 years. My name is Jessica, obviously. So in that 50 years, I've seen I would say, arc of diabetes go from guesswork to really high precision technology, and a lot more information. So I've used that to get involved in mostly advocacy work, for access to this information, to the care, and all of that. So I would do some work with the Diabetes Patient Advocacy Coalition and with grown up T1Ds.
Wonderful. I'm a big fan of both of those organizations. Thrilled you're here today. Sarah, can you please tell us a little bit about yourself and your relationship with T1D?
Hey, I'm Sarah. My relationship with T1D started about 5 years ago when my 2-year-old daughter at the time was diagnosed. I was at that time on a path to go to physician associate school, and I am now a PA. I practice in emergency medicine, so I see that side of type 1 diabetes. But I'm kind of just getting started now that I'm somewhat fresh out of school in the last year, as far as what I'm plugged into with advocacy and things like that. I did my kind of capstone project in school on type 1 and mental health, and kind of the long-term burden, the burnout that occurs for both family members, loved ones, and the type 1 themselves. And yeah, Dennis and I are neighbors and see each other frequently. I've talked about many of these things, and he has been, in the same respect that I talked about in my project, he's been a really important community member for us, kind of bringing us in and giving us information and guiding us and helping us not get burned out. And yeah, I'm very, very excited to be here.
And Dennis also serves as a wonderful example that you can live a long and healthy life with T1D. So thank you for that.
Absolutely.
All right, Pam, how about you? Can you tell us a little bit about yourself?
Sure. So my name is Pam Durant. I am based in Dubai. I've been living here for the last approximately 20 years or so, more probably. I'm a healthcare manager by profession, but as life happens, much to my surprise, when my son was 18 months old, similar to Sarah, 2 years old, he was diagnosed with type 1 diabetes. It was quite the shock and the journey. And I was in Dubai. He was born here, and there was no doctors that understood type 1, and really no support, no resources, no nothing. We didn't find a pediatric endocrinologist until about 3 years into it. And slowly over time, what I realized is there was a lot of work to do. After I found that doctor who invited me to, advocate and speak at certain scientific meetings I realized that there was a lot of work to do and people needed a lot of help. So about 9 years ago, I left the corporate world to start what I call social entrepreneurship, to support people with diabetes, because that was the fastest way that I could legally set up an entity to help people. And so what we do at DiaPoint, we have resources, education, support, community events, and also have an e-commerce platform, because I believe very much in making diabetes beautiful. Just as wearing glasses is kind of cool, right? Or at least, I think so. And Because if people embrace it in a different way, then it's still hard, but it becomes a little bit easier and a little more light than a lot of what we see and hear.
Yeah, that's wonderful. Thank you for all you do in that respect. All right, at this
Thank
point, Dennis, I'm going to turn it over to you to bring us through the agenda and lead the discussion.
Okay. Thank you all for being here this morning or this afternoon. I know you have busy schedules, and I thank you for taking the time out to discuss these important issues. Scott, again, thank you so much for producing this, and we're looking forward to having many more going forward. Okay, can we put up that first slide? Okay, so when I sent the agenda out and the preface for the discussion today, Pam was very nice and sent me a link to this organization, the International Diabetes Foundation. I thought that the numbers here would be representative of the diabetes community globally. So we're not using numbers just from one country or one organization. And I think it's important when you're looking at demographics to look at it from a community standpoint rather than from just where you are in a silo in the United States, Mexico, Canada, what have you. So on the first slide here, it's hard to read, but the graph, the line graph on the left, says as of 2024 or 25, there are 589 million, not thousands, not 10,000s, not 100,000, but millions of people who have diabetes, which is a conglomeration of type 1, type 1.5, type 2. Of those numbers, 10%, I believe, are type 1. Nevertheless, we all deal with diabetes every day, and some of the type 2s take it, so there may not be that much of a difference between them and us. They use CGMs, and some of them use pumps. The graph on the right side is a projection of what it'll be in 2050, approximately 25 years from now, and that's 853 million. And if you do the quick math, that's a 45% increase in the population of people who are going to have or become people with diabetes. And you notice I don't say diabetic, and that's from the Stigma situation. I try not to use that in the conversation. So we have a massive issue coming our way. These graphs are really demonstrating the age of the population of the world. If you look at the top graph, you remember from statistics, the mean is between 55 and 64 years old. Population of the world is getting older. There are less people being born. And in certain, like here in the United States, it's not as high as it used to be. Japan has the same issue with people getting older and younger people not having children. So this puts a stress on the entire system that will be supporting these people who are getting older because they're living longer because of the technology and what they're using. The next one is the difference between men and women. It takes no hostages. They both seem to be equal in the numbers. And this was at the end of the section, the first section. And if anybody who's watching wants to see this report, they could go to the PDF and they could download this report. And what it says at the end is diabetes prevalence increases with age. Therefore, the highest estimated prevalence is people over 65. In 2024, estimated number of people with diabetes aged 65 to 99 years was 158 million. And the current trend continues. The number of people aged 65 to 99 years with diabetes will be 278 million by 2025. These data points to a significant increase in the diabetes population aging societies in the next 25 years and the inevitable public health and economic challenges this will bring. It will require all countries to commit to sufficient resources to tackle diabetes. I think it says it pretty. Now, let me make a point here. This is from ages 20 to 79. This discussion will not discount anybody under 20 years old, as several panelists have children who are under that age. And because they may not be included in these numbers, then the numbers are maybe significantly higher. And that adds more insult to injury here in trying to cope with these numbers. So what does it all mean as far as numbers and capacity? So let me set up the argument here. I worked in manufacturing, and let's say, Pam, you're a customer of mine, you come to me and say, Dennis, I want you to make widget 1, 2, 3, 4, 50 a month for 5 years. That's 3,000 for 5 years. I know exactly how much labor, machinery, blah, 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 and all that. I know my cost of goods. I know my cost of sales. I know what my profit margin is going to be. In other industries, it's more cyclical or seasonable. Hula hoops, Christmas, traveling or what have you. So it's harder to decipher what those numbers are. So in the supply chain of medicine, it's getting more difficult for us to determine what the capacity needs are going to be. And if we knew and were within 80% of the projection, we'd be doing pretty good. If you ask anybody who's doing projection, you're in an 80% bracket, you're doing pretty good in your estimating. So the discussion is, how is the what and how? What is it? And the what is the numbers and the capacity, and the how is how are we going to tackle this in order for us to at least start trying to address the issues that are in front of us so that we have better outcomes as we go forward. And I'll leave the discussion open right now.
I think, Dennis, thank you for laying that case out for. We definitely have a challenge facing us. More and more people diagnosed with diabetes, and we're also facing a shortage of specialists in the area. Fewer and fewer people are getting into diabetes care as a medical specialty. So we definitely have some challenges ahead of us.
I hear those numbers and think, oh my goodness, all these people are going to have to be making these daily decisions about glucose monitoring, how much insulin or metformin or whatever it is to take, what their activity and food input is going to be. And I see a need for a lot of education of not just providers, but of patients, because diabetes is one of those few diseases that is self-managed, right? You don't go to the doctor and they change your dose and you go home. You go to the doctor, they look and see what's happening, and then you get sort of a guideline of how to work within what's happening and how to make decisions. So I see that the combination of the lack of professionals also impacting the demand that comes on patients living with the disease.
There's also a lot of discussion around burnout after COVID. A lot of the people who were in medicine decided to leave because of all the stressors that they had to go through in dealing with COVID, and that included those who treat and guide those who have diabetes. So that's another issue here. Sarah, how do you see from your perspective, since you're the new PA, congratulations. That's a fantastic accomplishment. How do you see that going forward in the next 10 years? Let's bring that scale down somewhat. Do you see it improving? Do you see more challenging?
As far as addressing burnout across the board, within the healthcare professional world, I think that overall it is progressing since COVID. Burnout is a big problem in healthcare. It's a huge problem. That being said, that has been recognized, and there are more and more committees and resources and things being implemented and started and changed to try to reduce that. So I do think it is still very much an acute problem, but I also feel like it is being addressed. And as far as the next 10 years go, I think it's probably a reasonable amount of time to start to see an improvement. I don't think that it's something that could be quickly improved, but I'm hopeful, myself included in that population, that we can address some of the root causes. And a lot of that is mental health. A lot of that is time burden. A lot of that is education on both the parts of providers, other healthcare staff, and also patients, reasonable expectations across the board. But no one knows if their expectations are reasonable or not unless they are well educated on the subject matter they're dealing with.
Pam, where do you see it from where you sit? Because you are, in a whole different area than we are here in the United States. So the stresses on Medicare and Medicaid. Britain has the National Health Service. They're seeing issues with their health service. Where do you see it going in your part of the world?
Yeah, it's very interesting, and I think there's a lot of similarities and some unique things as well. And I'm in the United Arab Emirates, the GCC, which includes some of the countries that are on the tables that you showed, like Bahrain, Kuwait, Saudi Arabia. All of these have a high prevalence of tend to be type 2 diabetes, but also type 1's increasing as well. Some of that is slightly genetic, but for type 2. And it's kind of the perfect storm when the standard American diet was exported to here and things changing. So there's one component when it comes to type 2, that's lifestyle. Type 1 diabetes is increasing in adults and children. And similar to what's happening in US, there are not enough providers, not enough physicians maybe focused on diabetes endocrinology, certainly not enough diabetes educators. Some of the governments, they do recognize nursing as a profession, but there's not a specific certification for diabetes education. So people that want to do this job have to really love it. And of course, any diabetes educator does it because they love it. But if you need to get certified, and if your specialty is diabetes, you need to look to other certifications. That's one thing. The other thing that I've observed in countries in the GCC, there's a lot of focus on the technology or what can they do genetically, looking toward the future. They're very forward thinking here, which I love so much. But at the same time, that leaves the actual person behind, because solving something genetically or with a pharmacokinetic thing, development is one thing, but still a person that has to do the work, manage it, deal with the stress, deal with the devices, all of these kind of things. So it's really complex. Insurance as well. So in the UAE, those of us that are expats here, which is about 80% of the population, we have more or less, it's kind of similar to the US. It's a private insurance system. Locals do have public insurance where they get supported through government programs. However, I can say from the private sector, they don't pay for prevention. By prevention, I mean, like in the case of my son, they'll pay for the endocrinology appointment, but not for diabetes educators, not for podiatry, different things like this that needs to happen. So there's a big gap. if we go outside the GCC to other countries, say in the Middle East and some in North Africa, the gap of access can be very big. I've met advocates from many different countries and some countries that have undergone a lot of economic challenges or other challenges. The question is, can I afford to buy insulin or put gas in my car? So I met a doctor who works in Ghana. She manages a clinic for young adults, kind of teenagers, young adults with type 1 diabetes. And she was telling me that some of them may only be able to check their blood glucose, I believe it was once a month or once a week. Test strips are so expensive. I've met some other educators from other countries where they face similar issues. Some of the stories are quite outstanding, and incredible advocacy and support from doctors and educators and others in the region. I mean, they're really, and actually some of the people that you see pictured on the front cover of that report that I shared with Dennis, those are actual people on the ground making a difference. So the disparities are big and every country has its nuances. And it would be lovely if somehow we could all start at the same level, the same baseline. I mean, we know access to insulin is a problem in still many countries as well. So that's kind of a high level summary. But when it comes to what's happening in Dubai and UAE, we're very blessed that things are available. They're not always covered by insurance. I do believe that they are relatively cheaper here. Even if you have to pay out of pocket, it's still cheaper than paying out of pocket in the US. Considering the situation right now, if I were to go to the US, and probably my health insurance isn't going to cover my son there, and I would have to pay out of pocket for his insulin, and we know that would be very expensive. So there's a lot of challenges, and it sometimes what I always say with diabetes, like waking up every day, I love what I do. There's so many problems to solve or challenges to solve that it can be difficult sometimes to decide which one to focus on.
So let me throw out a question. Jessica and I have been working with DPAC, right? And we finally got through Congress and signed by the president to have medicine extended for 2 more years. And there have been stories of a gal who lived in Alaska and she had to drive 200 some odd miles to get to an endocrinologist in Oregon to be able to speak to an endocrinologist or be online with an endocrinologist using, the internet. What do you think? Do you think this is a way to bridge that gap until more capacity can be found? And how effective and efficient has it been?
So I believe telehealth, telemedicine is fantastic. Of course, there's something to be said for meeting someone face to face, but no one should have to travel that far to see a physician. And it saves time. It allows for physicians probably to be able to help more people. If it's a new diagnosis, then telemedicine could be hard. But if it's a routine checkup and different things like this, then there is no reason why we shouldn't be using it. And I think a lot of countries that don't have access do use it to some extent. But again, it depends on infrastructure, different regulations. You can't just have a telemedicine call. I mean, you could, but you can't just have a telemedicine call with a doctor from another country that's not accredited where you are. So it would just depend on a lot of the nuances. And sometimes I even know in some countries, internet connections can be really slow. Years ago, I met a lovely team. They were based in Central America, and I apologize, I don't remember the country, but within this community, one of the guys went house to house to help the kids get connected to the internet so they could participate in an online camp. So if the infrastructure's there, then it's amazing. If it's not, it has to be updated to be able to support.
Definitely agree wholeheartedly with that. I think that telemedicine has bridged a lot of gaps for us. But at the same time, the populations that I see that struggle the most, right? That they have the most issues taking care of themselves or their family members are the same populations that don't have the resources to set up telemedicine, or they aren't all carrying a phone around in their pocket with access to the internet. So there is certainly a place for increased telemedicine, I think, especially within the diabetes educator world. Being able to have regular diabetes educator appointments for any family, whether it's, people that are caregivers or the person that's taking care of themselves, would be amazing. I mean, we obviously still need regular well checks and blood work and things like that, but just to be able to check in and say, hey, here's what my sugar's doing. Like, I'm struggling dosing these things. We're having these patterns. And to be able to get feedback from someone who is educated properly on how to give that information to you would be phenomenal. But there is the flip side, like Pam was saying, of a lot of the people that really truly need those resources don't have access to telehealth.
Yeah, and I can add, and I'm assuming, Dennis, you can too, based on how things were in the 60s and 70s and early 80s. A lot of this was done by phone, which is still an infrastructure problem. But now I can, my data automatically uploads, the doctor has it real time. I'm able to be seen on time and end on time and fit it right into my workday. I'm able to go after hours and do my lab separately. Like, all of this has really, really made the access to care for me that much better. But I do remember, having the paper logbooks with the 4-color pens, and the doctor asking me, where do you see all the red? And all the red was my highs, right? And all the orange was my lows. And, do you see a pattern? And sort of walking through that with the doctor on the phone to get sort of that feedback as needed, right? And it wasn't meant to be preventative or a regular appointment. It was, something's going wrong and I need to fix it. I found that very valuable in teaching me how to make those decisions and address them later, rather than just having the doctor look at my graphs and all that and say, do this, do that, do this, right? It helped me evaluate what my numbers were saying and what my options were.
Yeah, I can not medically, but mentoring. JDRF back in 2018, before they made the change, they set up a program where they paired you with somebody in your age bracket. And I had a gal who was 72 and she was an LADA person with diabetes, and she went on the tandem pump and the G6, and we met for 22 months, once a month, and we use the internet. You have a choice when you do mentoring. You could either do it in person, one-on-one, in a group, or you could do it via letters or whatever. So in December of 2022, I sent a email to this person, and I said, hey, it's time for us to have our monthly chat. And she wrote back to me and she said, Dennis, I'm doing pretty good. My pump is working as I expected to. My A1C is below 7, and I think your services would be better spent helping somebody else who's having more issues. And I wrote back and I said, listen, if you ever have a need or you ever want to call me, text me, whatever, I will always be there for you. And I hit the return key or the enter key, and I literally like balled up a little bit here, because of the availability of the technology to be able, on a mental state, to be able to help somebody. And if we could help just one person, one on one, we'd be doing a much better job than we are now. And unfortunately, there are not that many mentors to help many mentees. And that's an issue. So it brings me to the last point of this conversation. We have a mental issue here. Stigma. People who are dealing with diabetes, and Scott and I were part of he produced for us a thing on stigma. And for those of you who are watching, on the March 29th and 30th in India, there's a global conference on diabetes stigma, of which the ADA and Breakthrough T1D is supporting. So if you go to the pledge on the internet, you could sign up to support it. And there are thousands and thousands of people supporting it. There are hundreds of organizations supporting it. And also there are other companies such as Lilly and Tandem and all the pump supporting it. So how do we address the mental part? Because I always say you never control diabetes. Give you an example. At night, my blood sugar went up to 160, and this morning I had the same thing. It's 120. Why? So I'm not controlling it, right? So meanwhile, people say control, and they really don't control. So they need to understand what managing is, as to what Pam and what Sarah said, because it's a process, it's procedures. Our bodies are different. So how do we address the mental aspect of dealing with managing diabetes 24/7, 365 and a quarter days a year?
I'm a big fan of community in that aspect, right? Being exposed to and communicating with other people living with diabetes, and in the diabetes space, parents, you definitely, Sarah and Pam, you definitely count in that, maybe even more so sometimes, right? But also, I think that we are starting to see some positive changes with organizations like Destigmatize, and all the great work that Renza and many of her colleagues and peers have really spearheaded internationally. So we're seeing more attention on the mental and emotional health aspects of diabetes. So I think it's catching up, but we need some time, and we need to be able to manage well and cope well and be open to kind of exposing ourselves to those conversations, which can be a little bit scary from time to time. But I think that's one place to start.
I very much agree with what you said about community. This was a huge focus for me. Like I said, at the end of my PA school education, it's what I did my capstone project on. And, like anything else in life, you have to have other people to get through the hardest times. And oftentimes for people who have diabetes, the hardest times just don't end. They just don't go away. They might lessen a little bit, and then they come back later full force, and it's never over, which is why we have the burnout. I think that there are a few kind of ways to address this, from the family member, caregiver, and or a person with diabetes side. When people are first diagnosed, how incredible would it be, just in dream world, that when you leave wherever you were diagnosed, whether it's an office, a hospital, clinic, wherever, you leave with a diabetes educator on your team, you leave with a mental health professional on your team, in addition to your medical management team. Like, I know that is crazy to even think about. It seems so far-fetched, but I cannot fathom how beneficial it would be. And then from my perspective, as on the provider side of things, I am in the emergency department. It's where I work. It's where I see patients. It's where I encounter people on some of their worst days. And it is my own personal practice to literally practice commiseration, practice sitting in hard moments with people, not trying to force people to see the silver lining or it's going to get better. But, yes, this really sucks. This sucks. And just hear them out and listen and acknowledge their struggle and their grief and their pain, that this is ongoing and that it's never the same one day to the other. Because I can't even tell you the number of people, and I'm sure the number of times you yourselves have said or heard, I ate the exact same things and I gave myself the exact same insulin and I did all the same activities and it was still a terrible day for my blood glucose. It's just exhausting on so many levels. And, and I, the parent side of it, which I know Pam knows well, like you get so stressed out, you're caring for this other person. So then you have guilt on top of it. And it's just so difficult. It's so much to carry in the day to day. And my dream would just be for all the families and individuals affected by diabetes to have health, like mental health care resources at their disposal constantly. Sorry, that's my soapbox.
Exactly. Yes. And I think that the mental side of diabetes is discounted way too much because they think that people are complaining and what have you. And they're really not, because, walk a mile in my shoes, wake up in the morning. Like this morning, the PDM goes off, hey, you have to change your pod, right? So I look to see how many units I have left. I know I have this podcast to do. Do I have enough insulin to take me through to the end of this so I can rush over and put on a new pod? All of these responsibilities. We are a doctor because when things, as you pointed out, Sarah, go wrong, we have to say, okay, what did I do differently or whatever? And we try something different and then it works. So it's lessons learned. Making mistakes is a good thing because you learn from them. The other thing, you're a dietitian. You got to count your carbs. You have to do this. You're also a trainer. Well, you have to get off your backside, so to speak, and get out and do some exercises to burn off those carbs. You're also a nurse because you do the insulin and the pods and the insets and all the other things that go along with taking care of yourself. And lastly, you become your own psychologist because you have to deal with it every day. So it is a multitude of responsibilities that if you're not the A person, remember the, was that Briggs, whatever, A, B, C, and D. If you're not an A person and you're the worrier, those are the people who have the most stress. And the more assistance, the more help we can give those people, the better the chances of bringing them across the finish line. So I think we pretty much discussed what these numbers mean and what we need to do in order to start changing the trend of helping these people who have diabetes and to experiment with other things like telehealth to be able to bring to the population more assistance. And, when they talk about cost, it shouldn't really be an issue because it's only a line going from one person to the other, providing the infrastructure is there. So again, this was a pretty good discussion on that. So now we're going to get into our second topic, and that's information and accessing it. I belong to about 10 Facebook groups on diabetes. I also bumped into this DiaPoint person online, and we've been corroborating probably for the last 3 or 4 years. And it's really interesting to be able to hear a different point of view from the others. when you sit and listen to just all the stuff from where you are or where you live, it's kind of difficult to appreciate what other people are trying to do and accomplish. And then there are many organizations, and their quote vision mission is to find a cure, and the objective is how they're going to do it. But a lot of times it's different. So the diversity in the way they're going to prepare themselves to find a cure is much different than somebody else. So diversity is great because it gives us an option to use many different avenues to go down to get to the destination that we want to get to. And then on the other side, if there is too much variability, it's kind of difficult to keep up with all of the information that's out there. So I went to a site, and I wanted to read the report or the research. So I hit the link, and it said sign in. Well, I'm not a member of this organization, and others say you want to pay $25 for it. So I sat back and I said, okay, they made this big spread on the introduction about this report, and me, the person with diabetes, couldn't access it because I wasn't a member, or I didn't feel I wanted to pay for it, because I didn't know where the monies were going or anything like that. So with all of the information that's out there, with all the different organizations and everything, how do we create a repository of information where the people who need the information the most, and this is to Scott's point, and Renza, who was on our stick, she said, we have to bring it down to the community. We have to bring it to where the action is, to where the customer is, the patient is. How do we bring that down to them so that they can literally click on a page and find all this information that may either be similar or different, so there could be choices. There could be different thought processes. And this way, the confusion is eliminated so that they could follow it if they choose to. And this goes back to the numbers. Diabetes, there's 500,000 of these. There's 1.5 million of those. And you hear all the numbers. And after a while, you start going back and you said, well, they said it was this before, now it's this now. Like I printed out a report from Breakthrough. There's 2.03 type 1 diabetics in the United States. Then they came up with a quiz. How many people with diabetes type 1 are in the United States? And the answer was 1.5. So I asked, what happened to the other 500,000 people with diabetes? Did they get cured or something? So this is the confusion with all the data. So we need to find a way to bring it to the community. So how will we do that? Jessica, you have any kind of thoughts on that?
I think that's very complex, right? So if you go back to our first topic, we deal with things like you must get used to it, right? No, we don't get used to it. We learn to accept it and move on, right? So there's that type of education and stigma that we're dealing with. But then there's also at that community level, I know when I was first diagnosed, I was sent to the pediatrician, right? And I was at 4 years old, I was on 50 units of insulin a day. I'm not on that. So I can tell you how many times I went to the emergency room. So I think to some degree, the education has to be consistent and almost a requirement across providers that aren't specific to diabetes, right? You go to the emergency room, sometimes you are fighting for your own healthcare needs on top of whatever reason you're there. I recently broke my nose and they said, well, you can't eat anything. I said, well, my blood sugar is 60. I'm eating something. Well, you can't, you might need surgery. And that whole, if every provider outside the diabetes sphere had a basic level of understanding, I think that would go a long way. And I have very I find on the other end, from the patient end, right, the peer support, the mentorship, that all matters. When I was pregnant, I just kind of freaked out and I actually became a mentee. And JDRF was my lifesaver for that. I think more of that with also, the organizations providing it, providing enough training for the mentors will help. Uh, I stay away from social media. I have found the more I am on social media, the more confused I get. The more I start to worry, whether it's diabetes or something else, or the more I want to correct misinformation, right? You don't get diabetes from eating too much sugar, right? It's like, if I have to correct that on the internet one more time, I'm going to lose my mind. So I very much feel that since there's no moderation, we need to kind of shift that dynamic and say, get people to start going to the right places for information. And I think, again, that starts with the doctors. It starts with the support people. It's, and it's even the places like Joslin Clinic posting on their social media, go do these sites. But the sites need to have the information. And I think social media has become the place people go because the sites don't have it. And then, of course, you've got all the people who can't access social media and their doctors aren't providing a basic level of information. And that's where the nonprofit communities can come in.
Anybody else have any input on how we can consolidate information?
Probably a lot of us can talk for hours on this topic. Jessica, I'm like you. I'm on social media because I have a business, and you kind of like have to be, but every other day I'm still trying to figure out how to do it better meaning how to be there less. To do it. So at DiaPoint, we have a lot of free resources, so many. And DiaPoint was actually born from a blog where I was writing about my experience. My son just turned 18 in January. So I sat down to write a photography blog because that's what I was going to focus on. But instead, all this diabetes related stuff came out. It was quite therapeutic. And from there, I just kept writing and sharing my experience, not his personal experience, but my experience as a caretaker. And whenever I would find something of quality, share it. Information, I think newer generations are sharing more. There used to be that information is power and it's competitive. And even for hospitals and clinics, and they're all competitive. It's hard with, again, different countries. You're on one side of the world, the other, but the foundational things are very similar. And it's really important to kind of cross-pollinate, share a link to an organization if it's out there. Like where I live, there's a lot of people fasting for Ramadan. Ramadan and diabetes is a big topic. We have a free resource for that. And we do share that it comes from a group of doctors that developed this tool, and it's online and it's written quite clinical. But we reference back to it, and then we, translate it a bit into layman's terms. Plus, we mix in some of our mental health resources and other things. So it's very difficult when you're running a business because things have cost. You have to pay people to do it. You have to pay for the platforms that you put it on. And I made the conscious decision. It was faster to be a business instead of a not-for-profit. Bootstrapping, I did not take investment from anyone to do what I do. We charge for some things, but like products and other things like that. But for the absolute basic things that people need, we do it for free. And I wish, everyone or other companies and organizations kind of would follow that. And there are a lot that do that. And I think a lot of the work, like you mentioned, Renza, she's amazing. And a lot of the work that comes out of Australia and what they do and how they do it is so incredible. And I wish other countries would follow suit because I feel like they are really far ahead when it comes to free public information and sharing that and making sure people have access to that. It should be like that for everyone, but not every system can support that. But at minimum, it's it's giving more than trying to take and keep people in your ecosystem. And what I always say when we're doing something like this for free or whatever it is, I'm like, there are clearly enough people around the world with diabetes that there is enough for everyone. And it's a matter of all the clinics, hospitals, not-for-profits, other organizations just sharing and also not sharing what they know and not being afraid to share other resources or talk about other organizations that they know, because they know, and it helps people find each other, and it just builds a bigger community rather than just saying, hey, stay here in my container. I want you to cross-check me. I want you to go look at other resources. I learned stuff in the process. That's part of it. But that's really a long answer. The short way would say just be really open.
I think you bring up a great point, Pam, about you know, identifying champions and supporting those champions and helping them. You know, we all can't do everything, and there are some that will kind of naturally rise to champion that cause, and it's up to us to help support them and do everything we can do to keep them going and keep them motivated with that. And I think Renza and her colleagues in Australia, like you say, they really are trailblazers when it comes to many things in diabetes. And then here in the United States, witnessing like Jane Dickinson take up that cause and champion a lot of the language matters, for example. That's just one small part of that bigger picture. But really championing and supporting those champions, and also being brave enough to take a step out if there's something that you're passionate about, to share your thoughts on it. And you do have to have kind of a thick skin on the internet, which is a sad state of affairs sometimes, but also I think we have thick skin as people living with and dealing with diabetes as kind of a natural resource. So, but I really feel strongly about supporting the champions in the space. So that's a great point. Thank you for bringing that up.
Yes, and my inspiration came from Diabetes Australia. I really feel that they have their finger on the pulse. They really understand what it means to their population, what's going on. They were fighting for CGMs for everybody, I think, last year, and they finally got that passed and everything. But the people had a place to go. They had a home. They could get information. And Pam, to your point, a lot of the research papers. Now, when I worked, I bought $1 million machine tool to make parts. You have to put all the contracts together from all of the RFQs, and you have to go through the language and everything. I have the patience, and I understood the language of the contract. When they put these reports out, they need to put it in layman's terms. So they can, I don't care about the abstract, and I don't care about the means and all that stuff. We know you have to do that. That's part of good research and development. But the point is, what's the objective? What did you find out? And how are we going to use it? The what and how. And a lot of times the layman, who may not even be good at reading vocabulary wise, they have no way of being able to translate that into layman's terms so they can walk away and say, I understand. And it's difficult. It's very difficult. And I think that if you walk a mile in my shoes, going back to that, and these researchers would put it into layman's terms, I think they would get a lot more feedback from the people they're doing research about. I mean, that's what Renza said, right? We're doing research on these people, and yet we're making it difficult for them to obtain it, to understand it, and to walk away with value-added information. So it's very important. Are there any other?
Yeah, and I just want to add to that, because I think a lot of people, not all, but when they're writing their research or talking about it or presenting it, because they're presenting it to other researchers and other doctors, and I feel like sometimes it's lost in translation, even though we're all speaking English here, the same language. But if we had clinicians, like hardcore research clinicians, that maybe they're not interacting with people as much outside of their research, then the messaging gets lost on the way. And doctors sometimes assume we know, or they're overwhelmed and there's so much for us to learn about diabetes. I think sometimes there's a lot to do with that too, of why it doesn't get translated to us, because they got 15 minutes or how many ever minutes with us and they can't say it all. But yeah, research is written and done about people with diabetes, but the objective of research is for a lot of different reasons, which is a systematic issue more than a personal issue. But correct me if I'm wrong, Sarah. Like from a medical perspective, that's just what I observe.
Yeah, no, I agree. I mean, even as a medical professional, I look at these research things and I'm always, we have multiple resources. I don't know, good ways. In emergency medicine, we're not just endocrine, we're not just cardiology, we're very broad practice. And so we constantly use resources such as Up to Date and other things that just give us, medical published journal research information, whatever the most up-to-date ways to treat and diagnose are. And I read through some of these things and the majority of the time it's fine. Like I know what I'm looking for. But there are some things when I go down like a deep rabbit hole, which I don't often have time for, but, I get into the nitty gritty of some of these articles of like really specialty things. And that's not my specialty. And I certainly don't know what that means. And so, if I feel that way about some things, the everyday person who's just trying to find out more information about their diabetes, it's not helpful for them to look at that research article or that published journal article. Like, it's not helpful. I think this is another place where we have a big gap, right? And being able, not just being able to get access to the information, but having the information interpreted by the appropriate people to give in a different way to the people that need it, right? There almost needs to be some sort of in between. Like, here are the people that are doing this doctoral research and it's amazing and we need it, but also we need someone from that team or someone that works beside them to take that information, put it into layman's terms and say, okay, here's what we did. Here is how you can use it to benefit yourselves and others. Here's the takeaway, right? And there is no easy way to do that. That doesn't exist right now. And that is across the board in all specialties. But given the numbers that we know about diabetes, it's got to change in endocrinology. It has to change. There are so many people that, particularly type 2 diabetics that are insulin dependent, I think is a very specific population that the information and education is extremely lacking. Because they have gone through a whole metamorphosis, right? Most of the time, they started out on metformin or they started out on some sort of, Jardians or one of these other things that they can just kind of manage medically, but they just get worse and worse because maybe they didn't really have a conversation about lifestyle, or maybe they don't understand that it's just going to keep getting worse unless you change things, and then they end up on insulin. And insulin's a whole new ballgame, as we all know very well. However, how are they supposed to know? And so, that is a significant failing on our part. But even for those who are very intentional with type 1 diabetes families, when we are looking for information, it's still hard to find. And that's really sad and it's really frustrating. And I think that it is going to take a good amount of advocacy to the right people to get kind of that in-between person, whatever that looks like. I don't even know exactly who that person would be, this magical translator who's going to take all of this very specific research information and send it back out to us.
Yeah, if I may, a little bit of AI, but with human oversight.
Yeah. Yeah, that would be amazing.
Yeah. So I work in biotech and I've had access to every publication imaginable. I've also had access to people who write these things and why they write them. And I've been able to take a study and say, what does this mean so I can understand it? And particularly during COVID, it was amazing. And if newly diagnosed patients had what I had during COVID, like that would be great. Again, who is that, right? And AI can do some of it, but if it spits something out wrong, you could have a total panic attack. But the value of that is so huge. I do agree. The question is how do we get that out there? One of the things that the people I would go to did for me was help me identify the parts of the reports that mattered to me. And that was a big first step. And that might be something that we can do in more of a mentor or community place, is find, if you're seeing a phase 2 study, these are the sections you want to look at, ignore the rest. That may be an easy start, but it's not the solution.
Fantastic. That's great. And I think to what Sarah and Pam were saying, it's like playing telephone. You start with the first caller, and by the time it gets to the 20th person, that whole discussion, the whole meaning of it is changed because of the interpretation as it goes from one party to the other. So it would be nice to take it from a higher level and bring it down and simplify it, but put it in terms of validity and also easy to be able to understand. And maybe if more people understood what those reports were telling them, they themselves would become more involved to want to know more. By having reports that don't explain things in simple English or whatever language, German, Italian, whatever, these people actually box themselves into a corner, and they don't get involved because they don't understand. And understanding is probably one of the key things here with information. So I think that we've done a good discussion on it. So it's time to close out this session, and I'd like to thank Jessica, Sarah, and Pam, and Scott again for doing a great job of putting this together. And for those of you who are listening to this intense discussion here on numbers, capacity, and information, we'd love to hear from you. We'd love to hear what your comments are, what's your feedback, and do you have any solutions that you could suggest? And maybe we would pick up on them and have you join us at our next podcast so that we can continue with some value-added discussions and treat diabetes as a community. We are a community. It doesn't matter if you're living in the UAE, you're living in Mexico, the United States, Canada, China, wherever. We all deal with this each and every day, whether you're type 1, 1.5, or type 2, and it's necessary that we support each other. So to everyone here, I want to thank you for being part of this discussion, and hopefully we'll get some good feedback from it. Thank you.